Yes, hi, very good evening. So today we're going to have this live session on the topic occlusion. So we'll be discussing various concepts of occlusion, and we'll be discussing in detail the terminology, the balanced occlusion, different types of occlusion, and also we'll see what is the difference between a static occlusion and dynamic occlusion, various components of these occlusion, and what are the drawbacks if a patient doesn't have a near to ideal occlusion, right? So today we're going to have a detailed discussion regarding these topics, and I've shared the images of the text from our reference in our Google group, right? I hope you have the soft copy or at least the hard copy, right? So before proceeding with today's discussion, so it's breaking for everyone, because for me it seems to be streaming fine. I'm just checking it once again. Yeah, you're having intermittent breaks. Okay. Anyways, we'll just proceed and let me know if it is very much interruptive. Then we can think of. I can just go ahead with my mobile later rather than Wi-Fi, which I'm using currently. Yeah, it's on and off continuously. Right. So today, first we'll discuss about the concepts of occlusion, and then we'll proceed with MCQ discussion as well. So we'll have MCQ discussion at the end of the session, right? We have around 10 multiple choice questions, and we'll proceed accordingly. Yeah, it's breaking still. Yes. Because even yesterday we had this issue. I took the help of the YouTube staff. I contacted them. They said it's a normal thing and you can just proceed as usual. But still, again, we're having this issue. Maybe it's related to streaming or related to my internet connection. I'm not sure. Because even yesterday we had this blank screen at the end of the session, exactly 5 to 10 minutes before the conclusion of our session. Okay, just check for another 5 minutes and then we'll decide accordingly, right? Okay, in the meantime, I'll just go through the introductory part of this particular topic. We'll see till 9, it's 9:03 now, we'll see till 9:10, another 5 to 10 minutes. Let me know how it's going on. If you find it difficult to follow, then maybe we can discontinue the session, right? Yeah. So first of all, occlusion is a topic which we're all, most of the dentists are dreaded. In the sense, first of all, it's difficult to understand, presumably difficult to understand. And secondly, even though if we understand, we don't follow it practically because we underestimate the power of occlusion. We assume that most of the practitioners assume that we can proceed, we can practice without giving proper occlusion. But there are several studies proving that occlusion is not a separate entity. So the entire stomatognathing system is a part of your body and it's going to have an impact on various other parts of your body as well. And various studies haven't confirmed it scientifically, but they've proved that occlusion can potentially cause earwax. It can potentially cause temporomandibular disorders, TMDs, poor posture, excessive earwax, as I mentioned, speech defects. It's obvious, right? and there can also be prolapse of lumbar disc, lack of beauty, obviously, aesthetics is affected, and reduced strength in deltoid and rectus femoralis muscles. So it hasn't been proved scientifically, or we don't have this exact documentation, but it's speculated that occlusion can cause the following problems, potential problems. So what is this occlusion all about? So today we're going to discuss first about a static occlusion and then dynamic occlusion, and different types of occlusion we have, like canine guided occlusion, group function occlusion, and so on, right? And at the end, we'll have a brief discussion of various MCQs from the same topic, right? So we have this introductory part. I'll spare you from this introductory part. So it's given that occlusion is very significant. It's not that we have a right occlusion or wrong occlusion, because patients are not machines. We can't say that occlusion is right or wrong, but we can say whether a patient has an ideal occlusion or near to ideal occlusion, because no matter what the kind of occlusion is, we all do get accustomed to that existing occlusion. And unless and until we feel uncomfortable, we just carry on the entire life with the same kind of occlusion, right? So we don't have something called as right occlusion or wrong occlusion. It's wrong to say that. Instead, we can say whether a patient has an ideal occlusion or near to ideal occlusion, isn't it? So, first of all, the importance of occlusion in dental practice. So, occlusion can be defined, page 236 in the article which I shared, 236, the importance of occlusion in dental practice. Occlusion can be defined very simply as the contact between opposing teeth, isn't it? Before describing the significance of different ways in which occlusion contacts are made, occlusion needs to be put into context. We have something called as masticatory system and articulatory system. So masticatory system is that system which encompasses the following components, which include teeth, periodontium, and even most importantly, the articulatory system, which includes the TMJ muscles and occlusion. It's given in figure 2. You can clearly see that. The entire masticatory system doesn't just include your teeth and periodontium, but it also includes the articulatory system, which includes your TMJ, various muscles of mastication, and your occlusion, right? So your occlusion comes under this articulatory system. So this articulation system, teeth, and periodontium together comprise this masticatory system. So we can't just neglect occlusion, because these are all interrelated, isn't it? So why do we call this articulated system as a system? Page 237. Any system is nothing but which has components that can be linked together. So similarly, a system is defined as an assemblage that is connected or interdependent so as to form a complex entity. The articulatory system meets this criteria, and hence this system is a true system. In this articulatory system, one can imagine the temporomandibular joint as hinges, the masticatory muscles as motors, and the dental occlusion as contacts. So this articulatory system forms one of the components of your masticatory system along with your teeth and periodontium, as we have discussed previously. Now, coming to analysis of occlusion. To put that simple, as I mentioned, occlusion is nothing but contact between opposing teeth, not the adjacent teeth, but the opposing teeth, when you have this intercuspation or whatever. So, whenever we have mandible in a closed position, in a resting position, the occlusion which you see in that position is called as static occlusion. Whereas whenever the mandible moves in relation to the maxilla, then the occlusion which we see in that context is a dynamic occlusion. So the best example, we're all familiar with this. The best example for a static occlusion could be your centric occlusion. It's a static kind of occlusion, right? Whereas the best example for your dynamic occlusion could be canine guided occlusion, group function occlusion, balanced occlusion, mutually protected occlusion. We have different types of occlusion, right? So all this come under dynamic occlusion. So the contacts between the teeth when the mandible is closed and stationary is called as static occlusion, and the contacts between the teeth when the mandible is moving related to maxilla is called as dynamic occlusion. Now we're going to look into the components of static occlusion as well as dynamic occlusion, right? I'll just hold on for 2 minutes. Let me know how it's going on. Are you able to follow, or do you find it difficult because of the problem with streaming? Yes. Yeah. Hi, good evening. Yes, Rupali, you say it's not at all streaming fine. Sirish, not streaming fine. Hi, Neetu. Yeah, Niharika, the same problem. Okay. Prithvi says it's fine. Zina also says it's fine. Hi, Alvin. Hi, everyone. Okay. Okay. Do you want me to proceed? Because, I mean, initially we had this interruption. Even now, I think there is some slight buffering intermittently. Okay, it is streaming fine. Okay, perfect. Then in that case, let me just do as fast as possible because this is really unreliable. Even yesterday we had this issue. Right, thank you. So, as I said, masticatory system includes these components. But in dental schools, if you remember, we are taught mostly about teeth and periodontium, but we are not that much proficient in this articulated system, which includes the TMJ, occlusion, and muscles. So even that is equally important. So that's the intention which I'm trying to put. Now, coming to static occlusion. So first of all, static occlusion, as I said, when the mandible is stationary and when mandible is closed. In that case, what we see is your static occlusion. So in static occlusion, we're going to discuss about centric occlusion, centric relation. We have this ambiguity, like the definition of centric relation, right? So what is the position of condyle with respect to glenoid fossa? We're going to discuss all that in this live session, right? Yeah. So first of all, static occlusion. In that, we have this centric occlusion. So what is the centric occlusion? Centric occlusion is the occlusion where you see maximum intercuspation. It can also be called as habitual occlusion, or it can also be called as bite of convenience. So which we are used, or which the patient is used, the occlusion which the patient is used to, that can be considered as centric occlusion. So centric occlusion can be described as the occlusion the patient makes when they fit their teeth together in maximum intercuspation, ICP, or bite of convenience or habitual bite. So these are some of the synonyms for your centric occlusion. So centric relation, on the other hand, is something which is totally different. It's it has nothing. This centric occlusion is something which has to do with the relation between or the contact between the opposing teeth, whereas centric relation is that which has something to do with the bones, the maxilla and mandible. It has nothing to do with the teeth. So centric relation is not an occlusion at all. Centric relation has nothing to do with teeth because it is only centric, that is reproducible with or without teeth present. So even in edentulous patients, you can reproduce this centric relation. So centric relation is a jaw relation. It describes a conceptual relationship between maxilla and mandible. And we have different definitions for centric relation. Let me not just confuse you with all these definitions, but let me just put that in a straightforward manner. Centric relation is nothing but when the condyle, anterior aspect of a condyle, is in uppermost and foremost relationship with your glenoid fossa or your maxilla. Just remember, uppermost, foremost relation, uppermost and foremost relation of the condyle with your glenoid fossa is your centric relation. And also, we have different definitions for centric relation given. The other definition given is centric relation can be described as a position of mandible relative to maxilla with the articular disc in place when the muscles that support the mandible are at their most relaxed and least strained position. So it's relation between maxilla and mandible when the muscles are in relaxed and least strained position. And we have another definition, like centric relation can be described as a position of mandible relative to maxilla with the intra-articular disc in place when the head of condyle is in terminal hinge axis. So terminal hinge axis is nothing but a joint which rotates, around which rotation happens, right? So terminal hinge axis is assume that the condyles initially rotate and when you open your mouth and when you close your mouth, there will be pure rotation to some extent, right? So when you're closing your mouth, there is pure rotational movement, and when you imagine an imaginary line passing through these hinges, that is called as terminal hinge axis. So we have different definitions for centric relation. So just don't bother about all this. Just remember that centric relation is a relation between the condyle and the glenoid fossa when it is in the uppermost and foremost position. So previously it was assumed that the relation is uppermost and behind or the uppermost, but now according to the latest JPT definition, the relation is uppermost and foremost, right? And then significance of centric relation. So what is its significance? It is reproducible, unlike your centric occlusion, which can be habituated and which can vary. So centric relation, there may be arguments about the exact position of centric relation, how to position that best clinically. There is, however, a broad agreement between the dentists who have studied this subject that there exists a reproducible position of mandible relative to maxilla, and this position is reproducible irrespective of guidance without any inter-operator variability. Furthermore, there is inter and intra-operator reliability in finding it. So centric relation is something which can be reproducible. So it's a, what we can say that it's reproducible and it's a reliable record which we can obtain from the patient, right? So apart from this centric relation and centric occlusion in your static occlusion, so all these come under static occlusion, right? We have something called as freedom in centric. Freedom in centric occurs when the mandible is able to move. This is very important. Freedom in centric occlusion occurs when the mandible is able to move anteriorly for a short distance in the same horizontal and sagittal plane while maintaining the tooth contact. Let me just put that simply for you by showing this diagram. You can see here, right? So you can see this freedom in centric. So whenever the teeth are in occlusion, in centric occlusion, if the mandible is able to move anteriorly or forwards maintaining the same horizontal and sagittal planes to some extent while maintaining the intercuspal position, then we consider that occlusion to be having freedom of occlusion. Here we don't have this freedom of occlusion because there is interference and the mandible cannot move forward because of the interference from the opposing tooth. But here in this case, the mandible can move forward to some extent in the same horizontal and sagittal plane to some extent. So that is called as freedom of occlusion. Let me just read down the same which is given here. Freedom in centric occlusion occurs when the mandible is able to move anteriorly for a short distance in the same horizontal and sagittal plane while maintaining tooth contact. So this is called as freedom in centric. So in centric you have this freedom of movement, hence called as freedom in centric. If you don't have, then we'll say no freedom in centric occlusion. So this is another term which I wanted to explain that to you. And two common examples of occlusion that may not have this freedom are, so usually in any case we have this freedom of occlusion or freedom in centric is present in most of the cases except for two examples: angles class 2 division 2, where you have this you have this retrognathism or your maxillary laterals are palatally inclined. So in that case, you can't have this freedom in centric because they will hinder the lower teeth and there can't be anterior movement in the same horizontal and sagittal plane. And also, whenever you fabricate any crown or incisor relationships, like when anterior crowns have been provided with palatal surfaces that are too thick. So just look at these diagrams. So when, for example, you're given a crown here and you have prepared a palatal surface which is too thick or too bulky or over contoured. In these contexts, or in the context where you have this palatal inclined incisors, as in case of your class 2 division 2, there can be no freedom in centric because of the interference, right? So in rest of the cases, usually we'll have freedom in centric, and freedom in centric is nothing but forward movement of the mandible in same horizontal and sagittal plane while maintaining contact. So that is called as freedom in centric. Don't worry, I'll summarize all that we discussed again at the end of the session, right? Now, this completes static occlusion. So in static occlusion, we have discussed about centric occlusion, centric relation, importance of centric relation, and also freedom in centric. So before going into dynamic occlusion, I'll just take a 2-minute break and let me know how it's going on. Okay. Bite, this, I mean, bite can happen in any direction. You can bite in any way possible. But occlusion is something where you have this relation between your opposing teeth, right? For example, if this is centric occlusion, so the position where you have maximum intercuspation or where the patient bites habitually, right? So bite of convenience or habitual occlusion, that we can consider as centric occlusion. Anyways, occlusion is nothing but contact between two teeth, whereas bite is something like, for example, you can consider this as bite, right? So bite is something which you have a third material between your opposing teeth. That's my opinion. I don't know the exact definition for bite, but what I feel is bite is something where you place a third material between your teeth. But occlusion is the relation between your opposing teeth, the contact between the opposing teeth. Regina, I hope it's clear. Okay. Okay, just let me know. Is it fine or is it breaking? We'll go by the majority. We'll go by the majority because if few of you say it's breaking, but few of you say it's going on fine. I'm a little confused. So please clarify that for me. If it is fine, thumbs up. If it is not fine, thumbs down. Okay, Gina, Ashina, Preeti, Neetu, Shreyash, it's fine for you. Thank you. Thank you so much for letting me know. So Sanjay, it's fine. Good. Even Prithvi, Ashina, Pragina, Ananya. Okay, good. I think then in majority of the cases, even Mega. Fantastic. I feel relieved. Okay, how many have issue? Just let me know again. Because again, now it seems to be streaming fine for me also. Yes, Sirish, thank you. Abhishek, Niharika. No, it's fine. Oh, wonderful. Abhishek and Komal, right? Right. Then we'll proceed, okay, without wasting much time. Thanks, Ritz. Yes, Niharika. I mean, you raised your hand, Niharika. Do you mean to stop or do you want me to proceed? Yes, Sanchita. Perfect. Right. So far we've seen about static occlusion, right? It's very simple concept. I hope it's clear. Now let's go through dynamic occlusion. So dynamic occlusion, as I said, is when the mandible is in movement with respect to maxilla, and the occlusion which we see during the movement of mandible is your dynamic occlusion. So we have this working side, non-working side, balancing side, canine guided occlusion, mutually protected occlusion. So we'll try to cover up all these terms now. So the mandible is moved by the muscles of mastication, and the pathways along which it is moved is determined not only by the muscles but by the two guiding systems. Okay, right. Thank you. So this is very important. Please pay attention because when mandible is moving, it's not just the muscles of mastication that are guiding all these kinds of movements, but we have two guiding systems. We assume that mandible is moving because of action of muscles of mastication. So we have muscles which close the mandible and lateral pterygoid which works in an opposite direction and opens up the mandible, right? So it's not just muscles which are guiding the movement of your mandible, but there are two guidance systems. The first guidance system is called as posterior guidance system, and the second guidance system is called as anterior guidance system. So this posterior guidance system is formed by your temporomandibular joint, and anterior guidance system is formed by all your teeth. It's not just anterior teeth, it's formed by all your teeth. So the mandible movement is guided by not only the muscles of mastication or any other accessory muscles, but also it's guided by two guidance systems. Posterior guidance system formed by your TMJ, anterior guidance system formed by all your dentition. It's not just anterior teeth, but all your natural teeth, right? I hope it's clear. Now, let's go into the details. The posterior guidance system, page 242. The posterior guidance system of the mandible is provided by the TMJ. As the head of the condyle moves downwards and forwards, the mandible is moved along the guidance pathway, which is determined by the intra-articular disc and the articular surfaces of glenoid fossa. So during movement, I mean, we have seen one of the video previously where we discussed about TMD disorders and all, where you can see that the mandible or the condyle moves downwards and forwards, and then it articulates with the eminence, and then we have these movements, right? So the movement of condyle is obviously forwards. When you open your mouth, the condyle has to move forward and downward and medially, isn't it? That's your direction of movement of your condyle. So in case of posterior guidance system, which is guided by TMD, the head of the condyle moves downwards and forwards, right? So that's very important. If teeth are touching during a protrusive or lateral movement of the mandible, then those teeth are also providing guidance to the mandibular teeth. So it's not just a TMJ again, as I said, posterior guidance system, even anterior guidance system formed by your teeth also guide the movement of your mandible, right? We're going to discuss that. So if the teeth are touching during a protrusive or lateral movement of mandible, then those touching teeth or teeth in contact are also providing guidance to mandibular movement. This is anterior guidance, and this is provided by whichever teeth touch during eccentric movements of mandible. So far we have seen about two guidance systems. I hope it's clear. Now, no matter how far back, okay, anterior guidance system, second molars, that's all fine. Anterior guidance can be further classified into different types. One is canine guidance, group function, balanced, ideal occlusion, different sets, all of it. So anterior guidance may be further classified. So the first one is canine guidance. So canine guidance refers to a dynamic occlusion that occurs on the canines during lateral excursive movements of mandible, where only a canine is occluded on that working side and the rest of the teeth are disoccluded. So it's also called as mutually protective occlusion, right? So canine guided occlusion or protected occlusion or mutually protected occlusion. So canine guidance refers to a dynamic occlusion system. So it's an occlusal relation which is seen when the mandible is in movement, so it comes under dynamic occlusion. So this occurs on the canines during the lateral excursion of mandible. A canine protected occlusion refers to the fact that canine guidance is the only dynamic occlusal contact during excursive movement. Okay, let's leave it. Now we have something called as group function. So group function, as the name itself indicates, group of teeth function together or they occlude together. So in this type of anterior guidance, so canine guidance, group function, all these come under anterior guidance only, right? I hope it's clear. So in this type of anterior guidance, the contacts are shared between several teeth on the working side. If I'm moving my mandible towards my left, so we have occlusion being shared between different teeth all over, so that can be considered as group occlusion. In this type of anterior guidance, the contacts are shared between several teeth on the working side during lateral excursion. I hope it's clear. To qualify the term, to qualify for the term group occlusion, if we want to say that there is some group function, to use that term, we have certain criteria, and this is very, very important because this has to be differentiated from something called as interferences on the working side. We have something called as group function occlusion, we have something called as interferences on the working side. Both are not the same. We'll see the difference now. So to qualify for the term group function, the contacts would be towards the front of the mouth, and most of the anterior of the group would be the earliest and hardest contacts. This would contrast with the working side interferences, which infers a heavy or early occlusal contact towards the back of the mouth during excursive movement. Don't worry, hold on. If you are moving the mandible to your left side, if there are any contacts, heavy contacts between a group of teeth, opposing teeth, in anterior region like centrals, laterals or canines, then we can call it as group function. But if you have that kind of occlusal contacts between your posterior teeth, then it's considered as an interference on the working side. So that's the difference we have between group function occlusion and working side interferences. So this is very, very important. I'll just read that again, just try to get some clarity. So to qualify for the term group function, to use the term group function, the contacts would be towards the front of the mouth, and most anterior of the group would be the earliest and hardest contacts. This would contrast with a working side interference, which infers a heavy or early occlusal contact towards the back of the mouth during the occlusion, during the lateral excursion movements. And remember, a non-working side interference is an anterior guidance on the back teeth on the non-working side during lateral excursion. The working side is the side towards which mandible moves. So just remember, you have something called as working side and non-working side. So working side, non-working side. Non-working side is also called as balancing side, right? I hope you're all familiar with these terms. So when I'm moving my mandible towards the left, so this becomes the working side and the right becomes the non-working side, balancing side, isn't it? So you can have interferences even on the non-working side, right? So just remember, a non-working side interference is an anterior guidance on the back teeth on the non-working side during a lateral excursion. The working side is the side of the mandible towards which the mandible is moving during lateral excursion, and the non-working side is the side of the mandible away from the direction through which mandible is moving, as we have discussed now. I hope it's clear. You want me to clarify this particular terminology again? I'll definitely do it because I know it's quite confusing. Anyways, if you have still any ambiguity regarding this group function and working side interferences, just let me know. Yeah. So canine guided occlusion is, for example, when you make this, I mean, we had even this image-based question in one of the exams also. So canine guided occlusion is a dynamic occlusion where when you move the mandible laterally during excursive movements or lateropressive movements, only the canines on the working side are in contact. The rest of the occlusion is, I mean, the rest of the teeth are disoccluded. So that is called as canine guided occlusion or mutually protected occlusion. But in case of group function occlusion, group function occlusion, we call it as group function when you move the mandible towards the working side or towards one side which is called as working side, then the teeth which are in interference or the teeth which are in contact, the opposing group of teeth which are in contact, for example, centrals, laterals or canines, or for example, lateral canine and premolar, if they are in contact, then we call it as group function. However, if the posterior teeth like first, second and third molar are in contact during your lateral excursive movements on working side, then we call it as working side interference. So there is a difference between working side interferences and group function occlusion. So group function occlusion is seen in case of anterior teeth. The same kind of interference which or the same kind of contact which we see in a posterior region is called as working side interference. Just remember, you move your mandible to your left, right? So when you move your mandible to the left, you have some teeth which are occluding, right? If the teeth are anterior, then we call it as group function. If the teeth are posterior, which are in occlusion or which are having these contacts, not occlusion exactly, but contacts, then we call it as working side interference. So that's the terminology which they have framed here. Yes, canine guided occlusion, only the canines are in contact. The rest of the teeth are disoccluded on the working side. We're talking about the working side. So canine guided occlusion, just assume you're just moving your mandible to left. So left side is a working side, right side is a non-working side. Canine guided occlusion, only the canines are in occlusion on the working side. And group function occlusion, group of teeth anteriorly are in occlusion or are in contact. Whereas the group of teeth, if they are present posteriorly which are in contact, we call them as not group function but working side interference. I mean, non-working interference is nothing but it's called as group function again. So if you have this non-working side interference, it's called as or it's considered as group function again. Interferences are not normal. They're not normal. Normal is seen. Because if you have interference, again, you can have some problems. Anyways, we get accustomed to it. So interferences are not a normal finding. Unless and until there is some underlying cause, like as you said, crossbite or a tongue thrusting or any rotational movements, or when there is no proper occlusion. And working side interference, which, I mean, you're talking, someone asked about non-working side, right? Yeah, Ashina. A non-working side interference is an anterior guidance on the back teeth on the non-working side during lateral excursion. So, non-working side interference, we call it as anterior guidance, because these are the teeth which help in guiding the movement of mandible. So that's considered as anterior guidance, and that's what exactly is given here. A non-working side interference is an anterior guidance on the back teeth on the non-working side during lateral excursion. Right? I'll just proceed, okay? And then we have something called as ideal occlusion. So what is this ideal occlusion? So page 243. So we have this anterior and posterior. We have this interferences, guidance, and all this we're discussing now, right? Just pay attention to this particular statement. Just remember, you have this axis where you have a movement of a mandible, right? Opening and closing. So this is the axis, right? So when you compare anterior teeth and posterior teeth, where do you think, if there are interferences, would object to the opening of mandible or would object to the opening of the condyle? I mean, for example, you have interferences between the teeth anteriorly and posteriorly, which would more affect the opening of the mandible. Is it anterior or posterior? We have an answer here. Posterior interferences are considered to be a less ideal type of dynamic occlusion. And the term ideal relates to whether or not it is ideal for another part. Remember, anterior guidance on the back teeth while still maintained because of interfered posterior guidance system. Because the posterior teeth are closer to your opening axis, they cause more effect, or they're considered to be more damaging to the opening up of the mandible. Whereas when you have interferences on the anterior teeth, so these anterior teeth are placed farther from your opening axis, hence anterior guidance provided by front teeth is potentially more ideal for TMJ for simple reason that it is farther away from the temporomandibular joint. Exactly. So you gave the answer, right? Posterior. So when you compare anterior guidance and guidance given by anterior teeth, and I shouldn't say posterior guidance because posterior guidance is something which is provided by TMJ. In anterior guidance, we're talking about anterior teeth and posterior teeth. So the posterior teeth interferences are going to have more effect on TMD rather than anterior teeth, because anterior teeth are placed farther from the fulcrum. So this acts as a fulcrum, right? This is very important. So your condyles, we have fulcrum here. Your muscles which affect the movement, they provide this effort, and you have this occlusion which is nothing but your load. So this represents your entire oral cavity or stomatognathic system represents class 3 lever principle, where you have fulcrum provided by TMJ, where you have effort provided by your muscles, onto your occlusion where you have this load. So fulcrum, effort, and load. So this kind of orientation is seen in class 3 lever principle. I have written the same in page 245 in the soft copy. So that's one important aspect which I wanted to discuss. Now, what is this ideal occlusion? The coincidence of centric occlusion in centric relation, when there is freedom of mandible to move slightly forward from that occlusion in the same sagittal and horizontal plane, then we consider that as ideal occlusion. I hope it's clear, right? So centric occlusion coinciding with centric relation and having freedom in centric, which we discussed previously, is considered to as ideal occlusion. Now, when the mandible moves, there is immediate and lasting posterior disclosure, anterior guidance on front. For example, all of you just try this. Move your mandible onto your anterior teeth. So first start with centric relation or centric occlusion. or your habitual bite, and then move your mandible anteriorly. So when you move your mandible anteriorly, there is posterior disocclusion and there is guidance of your mandible by your anterior teeth, isn't it? So even that can be considered as an ideal occlusion. So in case of ideal occlusion, you have these characteristics. Centric occlusion coincides in centric relation with freedom in centric. That means mandible moves horizontally. Mandible moves in a forward position in a horizontal plane and sagittal plane, the same horizontal and sagittal plane, by maintaining the contacts between the teeth. So centric occlusion and centric relation coincide. At the same time, mandible is able to move anteriorly in the same horizontal and sagittal plane while maintaining the contact simultaneously. That is nothing but freedom in centric. So that can be considered as an ideal occlusion. And also, in ideal occlusion, when you move your teeth anteriorly, there is posterior disocclusion with anterior guidance. So these are some of the characteristics of an ideal occlusion. I hope it's clear again. So the occlusion means contact between the teeth, the last page. The application of force from the muscles through the occlusal contacts results in a load. Whether that load produces damage to the tissues will depend upon the several factors, which is again very important. So occlusion is the contact between teeth, and your temporomandibular joint acts as a fulcrum, and the muscles produce effort and there is a load acting on your teeth. So the load produces damage to the tissues or not depends upon the resistance of tissues and the restoration, that is the capacity of tissues to take up the forces, the magnitude of the force applied, the direction of the force which is acting, and the frequency of the force, as in case of bruxism where you have more forces acting very frequently, and the number of contacts transmitting that force, that is number of teeth in occlusion. So these are the factors which decide whether the load which is produced as a result of the process is affecting your tissues or not. So whether that load produces damage to the tissues will depend upon the resistance of tissues or restoration which you place, the magnitude of the force, the direction of the force, the frequency of force being applied, and the number of contacts transmitting that particular force. The purpose of understanding these terminologies and following them, because it's not just learning for a theory's sake, but when you apply the same practically, when you try to maintain occlusion, when you try to analyze the patient for proper occlusion, then you can avoid various potential problems. And also, the purpose of guidelines of good occlusion practice is to reduce the risk of damage occurring to the interrelated tissues of masticatory system. So increase the chances of healthy function. This will reduce the chances of disease, mechanical failure, dysfunction, or pain, and dentists can positively influence the factors as part of their care. And you know what? There is one interesting chart here which the authors say that occlusion has to be analyzed before you start any treatment. That's very important. And here you can see, I'll just go through it once. So this flowchart contains the following information, right? It's given in page 244. You can just have a look at this first and then we'll have a brief discussion. So before you start any case, the occlusion of the patient has to be understood first, because ultimately if you do a simple restoration also, that's going to affect the occlusion, isn't it? So how do you analyze occlusion? So what factors should we analyze while you're observing the occlusion of patient? It's not just angles, class 1, class 2 or class 3 relation. That is incomplete. That's totally incomplete. So along with that, we should observe whether the centric occlusion is coinciding with centric relation, whether centric occlusion is there, whether the occlusion is proper, whether there are any working side interferences, how the guidance is, how the anterior guidance is comparatively, whether there are any interferences on working side or non-working side. So we have to consider all these factors, and this chart represents all of that. So it's given that static occlusion, does centric occlusion occur in centric relation, yes or no? Is there any premature contact in centric relation? What is the direction of slide from centric relation to centric occlusion? Is there freedom in centric occlusion, freedom in centric, which we discussed previously? And what about dynamic occlusion? Are there any non-working side interferences, working side interferences, canine guidance, group function, crossover position? So we need to consider static occlusion as well as dynamic occlusion, understand the case, and then proceed with any kind of treatment, especially when I'm proceeding with crowns, restorations, inlays, onlays, or any kind of restorations for that matter, right? So this completes the basic part of occlusion, right? So we have a lot many terminologies, often they are confusing. So the objective of this live session is to simplify these terms for you. I'm not sure how far I've been successful. Anyways, we'll summarize once again, and you have any questions, drop them now in the live chat. Hi, Sushruta. Sushruta? Sushruta, hi. We'll just wait for a few minutes and then we'll proceed with MCQ discussion, right? It's unfortunate that today we had this issue with streaming. Anyways, I think it's streaming fine now. I just wanted to read this. Crossover means I reckon it's crossbite. Shreyash? Right. So I just wanted to read this because I just want to give you much more clarity regarding this guidances. I said mandible is moved not only by muscles but also by two guidance systems, posterior guidance and anterior guidance. Posterior guidance is nothing but the guidance provided by your condyle, temporomandibular joint, and anterior guidance is something which is provided by all your teeth, posterior teeth as well as anterior teeth, right? Anterior guidance, therefore, on back teeth. So you have anterior guidance on front teeth as well as back teeth, anterior teeth as well as posterior teeth. However, anterior guidance, therefore, on back teeth, while still providing anterior guidance to mandible, is described as posterior interference because it may interfere with the posterior guidance system of mandible, namely TMJ. So that's the reason why we discussed previously that group function is something which is seen in front teeth, but the back teeth, whatever contacts you see, that is considered as interference, but not group function. I hope it's clear again. I'll just read out this sentence again. This is very important. Understanding the concept is very important, then you can answer any question no matter how it is framed. Anterior guidance is something which is provided by front teeth and back teeth. However, anterior guidance on back teeth, while still providing anterior guidance to mandible, is described as a posterior interference because it may interfere with the posterior guidance system, which is nothing but your TMJ. Hence, posterior interferences are considered to be a less ideal type of dynamic occlusion. However, the anterior guidance provided by front teeth is potentially more ideal for TMJ for simple reason that it is farther away from your temporomandibular joint. Just assume that you have this a bar, we have this instrument placed here, right? So if I hold my instrument here, so assume that this is your fulcrum. This is your instrument, right? I have to move this instrument. If I hold the instrument closer, like your posterior teeth, you just can't move it efficiently. But once I hold the instrument farther, it will be easy for me to move. Or just assume that this is your fulcrum again. So I have held the pen closer. So when I'm trying to move, it will be difficult for me to lift the finger. But when I place it farther, I'll have more force generation and I can put more effort easily, right? It's not that the effort, the energy is, I'm not gaining energy in the process, but the effort increases. So that's nothing but a principle of lever. If you observe, we have three principles, right? Just go through them, it's quite interesting. So you have this, we have this system where they say, in order to lift a heavy stone, what do? We have a huge stone here. To lift that stone, what do? We can't lift it, right? So we place a third material between the stone and the ground. We wedge it, and then we take the support of another stick and then try to elevate it, right? That's how it works out. So the teeth which are closer to your TMJ, they are considered to be less ideal because they are not efficient in providing the guidance as such. The posterior teeth are not efficient in providing the guidance to mandible. They can't move the mandible clearly. But anterior teeth, as we have discussed with all these examples, they're farther away from fulcrum, so it is easy to guide the mandible. Right? I hope it's clear. Yes, Firas, that's a very good question. So, does it mean to say that we should compromise on the quality and do some kind of nonsensical treatment that's been happening right now in the clinical practice? You just can't say I have too many patients, I can't handle them. That's our problem, isn't it? You should have more workforce to handle. But as your literature says, you have to take care of occlusion, and there is no point in ignoring occlusion. And prove me that occlusion is not significant, and I would definitely agree to what you say. We just can't cite the reason that too many patients, I can't give quality treatment. Then it's not there. It's obviously our fault, isn't it? Anyways, that's what is happening in the clinical case scenario in the present modern way. Yeah, Regina, I'm sorry. I think I missed that question previously also. Yes, Prithvi, thank you. So, what is the definition between maximum intercuspation and centric relation? You mean the difference between Regina? Centric relation has nothing to do with the teeth. It has nothing to do with your teeth. Centric relation has something to do with your bones, maxilla and mandible. That's it. Intercuspation is something which has to do with your teeth, whereas centric relation has something to do with your relation between the condyle and glenoid fossa, that is the mandible and maxilla. You just can't say that, Regina, because yeah, that's what even I feel. When you can't handle too many patients, we shouldn't treat them. We shouldn't say that I'm too busy and provide them some. I mean, you know what? You have this T scan, just Google out T scan. You have this excellent device which analyzes the potential of occlusion all over your oral cavity. And I have attended one seminar during my post graduation where they mentioned that even a high point of 70 microns, which is not even visible to your naked eye. By the way, 1000 microns is 1 millimeter. So even a high point, when you do a restoration, even a high point of 70 microns can lead to enormous forces acting on that particular tooth, which will definitely alter your occlusion. And gradually, there can be a lot many manifestations. As we have seen previously, there can be TMD problems. It's not you will get, there is no direct causal relation between occlusion and this, but there is a greater chance or potential for developing these disorders. So occlusion as such is a very important entity. You know what? There are people who suffer because of lack of occlusion. In the sense, they have constant pain, they have constant problem in eating, in speaking. Even when speaking, many people have many problems because of lack of occlusion or improper occlusion or lack of an ideal kind of occlusion. Yes, Prithvi. Yeah, I mean, just it's a simple logic. You just can't have whole food at once early in the day and say I have eaten a lot, so I just can't. I mean, it's simple that you shouldn't handle something which is beyond your capacity. As simple as that. That's it. If you try to handle, it's going to get collapsed, no matter what task it is. Right. Anyways, you have any further questions? Do let me know. So, shall we proceed with MCQs? I think those who have missed this live session, I think you can just go through the recorded version also. Right. Okay. Shall we have MCQ discussion? It's not T scan, it's T scan. T scan. So we'll just proceed with MCQ discussion then. I mean, there is one quote which I mean I've heard Robin Sharma saying this. He says like we often feel like we are too busy. I also mentioned this quote or phrase previously. It's like you're driving on a. I mean, Fauzi or someone asked this question right regarding we have too many patients and how do we check all these things. It's like I mean I think I can draw an analogy and compare this here. You're driving on a highway on your car and you're traveling, and you say you're too busy to stop for gas or petrol or diesel or whatever. It's something like that. It's essential, right? You just can't ignore that and override and then proceed, unless until it's a solar power. Even solar power, you need to stop for charging. So there are certain things which are essential. I know clinically it's challenging, but remember once you do, it's not just about money, right? So you have a lot many patients or don't have patients, but what if you're earning a lot, but you're doing something nonsense out there? You're affecting the oral health of many people every day. It doesn't really give you a sense of satisfaction. Do one case, that's what I feel. Take one lecture, do one case, talk to one student, do it wholeheartedly, give you 100%, then I think that would be sufficient. It's not the number game, right? Then if it's a number game, obviously I should feel depressed first because I see Taylor Swift's channel, I see Justin Bieber's channel. You have crores of views and you have millions of followers or subscribers. And what about me? Something like that, right? Whatever we do it, I think if you do it wholeheartedly, that sense of satisfaction I feel is more important than anything else. Money, of course, will give you happiness, but that becomes secondary gradually as you go on. Okay, so Rupali, so you have a revelation today. Good. I mean, there is no direct causal relation, and don't say that I have told that. I mean, don't say that Naveen has told that occlusion, improper occlusion, can lead to earwax. There is no direct causal relation, but it has been shown that it has the potential of causing more earwax, not direct relation. Okay. So we have our first question. Just try answering it. In the meantime, I'll just go through the comments. So the question is: masticatory system comprises of teeth and periodontium only. Option B: articulator system only. Articulator system means not the articulated device, but the temporomandibular joint, occlusion, and your muscles. Option C: both A and B. Option D: none. Exactly, Preeti. Exactly. Anterior guidance is provided by anterior teeth as well as posterior teeth. And posterior guidance is something which is provided by TMJ. Clear. But the anterior guidance provided by posterior teeth is not that good. That's considered as an interference rather than a guidance because posterior teeth are located close to your fulcrum, that is your condyle. I hope it's clear. Yeah, thanks, Ananya. It doesn't matter even if it breaks now, right? We have these questions. Yeah. So masticated system comprises of, so we have an unanimous answer. Good. So it's not just your teeth and periodontium, but also your TMJ, muscles, and your occlusion. So that's called as articulator system. So teeth, periodontium, and articulator system together comprise the masticator system. Yes, Riddhi, surveying important from entrance point of view. I've seen a couple of questions on surveying. I'm not exactly getting it now. I mean, drop a mail, Prithvi. I'll just go through the previous papers once and I'll let you know. Yes, Regina, they are very much treatable. Anyways, I'll give you my opinion also. I mean, there is no point in extracting. We have sound crown structure all over. We can go for processes. That's not at all an issue. So we'll discuss that again. So second, occlusion can. Yes, Firas, that's the spirit. So second one, it's a direct question. Occlusion can potentially cause all of the following except. So occlusion can potentially cause all of the following except. So as we discussed, there can be post excessive ear wax, TMD, lumbar disc prolapse. So we have a lot many potential causes because of poor occlusion. So option D, none of the above is the right answer. Okay, right. I hope you're noting down your scores. So you have your third question. Centric occlusion is also called as ICP, intercuspation position, bite of convenience, habitual bite, all. Often we go only with maximum intercuspation, but remember we have discussed that in our live session. Centric occlusion is also called as not only intercuspation but also bite of convenience or habitual bite. Do you agree? So what is the right answer? Right. So option D is the right answer. Good. So all of them. So now we have fourth question, two statements, statement one and statement two. Statement one, contacts between teeth when the mandible is closed and stationary is called dynamic occlusion. Statement two, contacts between teeth when the mandible is moving relative to maxilla is static occlusion. So are both the statements true or both the statements false? One is true, the other is false, or vice versa? Do let me know. Okay, for those who for whom it's not breaking, can you just help me by writing down the right answer? So the first question, the right answer is C. Second question, it's D. Third question, D. Fourth question, both statements are false. Can anyone just take the lead and write down the right statement, the right option, right? So both options are false because the opposite is true. So when mandible is static and stationary with respect to your maxilla, then it is static occlusion. Dynamic occlusion when the mandible is in movement with respect to your maxilla. Yeah, thank you so much, Neetu, Zina, Shreyash. Okay, one of you can take the lead, right? Thank you so much. One of you, okay, let me say that. In that case, the first one to reply, Neetu. Neetu, please go ahead and give the right answer for each question after the discussion. So we have your fifth question. Centric relation is uppermost retruded position of condyle to glenoid fossa, uppermost relation only, uppermost and foremost position. Option D, none of the above. So which of the following describes centric relation accurately? We still have a lot many challenging questions. Let's see how it's going to happen. So we're done with 5 questions. So right. So centric relation is uppermost and retruded or foremost. So as per the latest definition, it is uppermost and foremost position of condyle with respect to maxilla. Option C, fifth question, option C is the right answer. And I just wanted to say something today. Just want to take this as an opportunity to say that I have few important people in my life. Of course, my parents, and then next my better half. So today is my better half's birthday. So I just wanted to inform you that, and I asked her to come live and say hi to all of you. You can check here and say hi.
Hi everyone.
So this is my small family, and obviously you know this guy. She is Toffee. She is Toffee.
Bernice will not agree if you call her
Bernice
T.
is not live. Bernice is not live today.
Okay.
Okay. So just say all the best to them, and we can just.
Yeah, thank you so much, and all the best, guys. Okay. All the best. Prepare well. Okay. Yeah, thank you. Thank you, Pooja, Kavya, Komal, Zeena, Shreya, Ananya, Megha, Prithvi, Pooja, Neetu. Yeah, thank you so much. Thank you from Toffee also. Thank you.
Toffee, say thanks. Say thanks. Okay.
Okay. Bye, guys.
Yeah, thank you so much for your wonderful wishes. No, I had this complaint, so I had to take her outside between 6 p.m. and 8 p.m. and then we had to run again back home. Yeah, definitely I'll convey all your wishes to ma'am once again. Thank you so much. We'll definitely have a live session, sure. And the topic will be handling relationships. It's not just married couple, even lovers can attend that session. We'll have that soon as possible, right? Thank you. Right, so we'll proceed with our sixth question. Mandible opens by. Right. So we have our sixth question. Mandible opens by rotation initially followed by translation forwards and downwards. Option B, rotation initially followed by option B is translation followed by rotation. Option C, rotation followed by translation forwards and upwards. Option D, none. So mandible opens by. So that's the question. Yeah, Ashina, thank you. I'll definitely convey convey all your wishes to my wife again. Yes, Neetu, thank you. I'll take that as a compliment. Yes, Prithvi. As I said, everyone has their own priorities. So obviously, you're all my priority, and you will be my priority. And not just you, even my family simultaneously, right? Again, she's going to get angry. Yeah, Rupali, thank you. Thank you, guys. So, sixth question, mandible opens by. So, which among the following is the appropriate option? So initially, when mandible opens, you will have this rotation movement followed by translation, and this translation, the movement direction is forwards, downwards, and medially, right? So obviously, option A is the right answer. Yeah, bingo. We have an unanimous answer again, which is good to see. Good, good, good. Right. So let's proceed with our next question, the seventh one with two statements. So, two statements. The first statement, yeah, mandible is moved by muscles of mastication, and pathways during which movement occurs is determined by muscles and guidance system. Statement 2, posterior guidance system is provided by posterior teeth, anterior guidance system is provided by anterior teeth. So which among the following statement is true, or if both are true, or whether both are false, or which among the following is true or false? Good. So again, an unanimous answer. So where is Abhishek? I think Abhishek has gone offline. Abhishek, Ramesh, no Ben is also today. Yeah. So the first statement is true. So mandible is moved by muscles of mastication and also it's guided by two guidance systems. Statement 2. Posterior guidance system is provided by posterior teeth. Anterior guidance system is provided by anterior teeth. That is false. So posterior guidance system is provided by your mandible. I'm sorry, the temporomandibular joint. And anterior guidance is provided by obviously your all teeth, the entire dentition. So the second statement is false. Good. So first statement is true, second statement is false. So now we have an assertion and reason. So assertion, centric occlusion and canine guidance are static and dynamic occlusions respectively. Reason, centric occlusion occurs when the mandible is closed and stationary, whereas canine guidance occurs on canines during lateral excursions. So let me know whether both statements are true or false, and also let me know whether there is justification between assertion and reason. So my charging is running now. In the meantime, I'll just charge my device. Okay, just give me 1 second. In the meantime, you just go ahead answering the questions. Okay, fine. I'm sorry, guys. Sorry for the interruption. Extended sessions, we have this problem, especially live. It's consuming a lot of battery. Right. So, who said man is wise and beautiful? She is not. I am more wise and handsome. Comparative. Right. So, assertion and reason. So, you say both are true and justified. So, all of you stick on to the same thing? Good. Yeah. So, assertion, centric occlusion, and guidance are static and dynamic occlusions respectively. So centric occlusion is static and canine guidance is dynamic, and also centric occlusion occurs, so that's the justification we have, when the mandible is closed and stationary, and canine guidance during the excursive movements of mandible. So both are true and the reason is justified. So we still have just two more questions and then we will conclude. Okay, Priti, now stop fighting with me. What, Ashina? Are you warning me? Thanks, Regina. I'll take that as a compliment. Okay, Gina, I'll just give you her number. You can just directly talk to her if you want. Yes, Neetu, both true and justified. So we have our penultimate question. When mandible is moved on left side, working side interferences and maximum movement of TMJ is seen in option A, left posterior teeth and right TMJ. Option B, right posterior teeth and left TMJ. Option C, left anterior teeth and left TMJ. Option D, right anterior teeth and right TMJ. So which among the following is more appropriate answer? So when mandible is moved onto the left side, working side interferences and maximum movement of TMJ is seen in. We have no answers. Surprising. I think this is the first time where there is a lot of gap between the question and answer. Good, Shreyash. Koman. Wonderful. Yes. Suresh, Preeti, Zina, Ashina, Sanjay. Yes, Rupali. Good. Yes, Sanavali. Yes, Neetu, Pooja, Prithvi, Mega, Regina. Good. Right. So when mandible is moved to the left side, obviously the left side is working side and the right side is non-working side. So the question is working side interferences and maximum intercuspation of TMJ is seen in. So obviously when you move towards the left, so working side interferences are seen towards the left because the left becomes working, the right becomes non-working or balancing side. So left posterior teeth, we find working side interferences, but not left anterior teeth, because whatever you see anteriorly, the relation that's considered as guidance, whereas posteriorly, whatever you see, that is considered as interference. So left posterior teeth, we see working side interferences. And what about maximum movement of TMJ? Just remember it's opposite. When you're moving towards the left, the right TMJ is working more. It has greater movement because it has to move in order to guide your mandible towards the opposite side, but not the same side TMJ or condyle. So left side posterior teeth and right TMJ, option A is the appropriate answer. Yeah, Shina, why would I mind? I'm just kidding. Me too. Yeah, we have one final question. I think we're still having this interference, right? So it's option A. I hope it's clear, right? So left posterior teeth interference, right TMJ, maximum moment of TMJ, right? Okay. We'll proceed with the final question for today. Yeah. 10th question. Which of the following is more ideal? Anterior guidance provided by posterior teeth, anterior guidance provided by anterior teeth, posterior guidance provided by posterior teeth, posterior guidance provided by anterior teeth. So which among the following is considered more ideal? Thank you, Neetu, once again. Come on, this is the final question. All of you who are live, try answering this and project your scores simultaneously. Yes, yes, Ashina, Prithvi, Preeti, Anovali, Zina, Ananya, Shreyash, Shrish, Megha, Neetu, Regina, Rupali. So as I said, the anterior guidance provided by posterior teeth is not that ideal because you have the fulcrum here and the posterior teeth are closer to fulcrum, so they are not effective in guiding the movement of mandible. So anterior guidance provided by anterior teeth, because they are placed more farther away from the fulcrum, they are more efficient in guiding, right? So anterior teeth or anterior guidance provided by anterior teeth is more ideal comparatively, right? So project your scores now. It's option B for 10th question. Yes, Shreyash, you have to do that first. Yes, Prithvi. Excellent. Yes, Regina. 7 questions out of 19. So you got 19. Good. Good, good. Keep working. Right. So Shrish, 35. Very good. Mega, Neetu. Impressive. Yeah, 10 is B. Zina, you're on fire. So 40 on 40. Excellent. Good, Rupali. Yes, Preeti. Good, good. Yes, Neetu, thank you. Right. So good. Keep it up and try to maintain the same momentum. That's very important. Okay. Question 9, it's option A. Ninth question, it's option A. Right answer. So keep the momentum going. Don't get demotivated at any point of time. Just keep yourself motivated by assuming that you're the topper in this year's exam, no matter what the format is. Just exude that confidence, not just in thought, but also in action. That's very, very important, right? So if you have or if you need any guidance or support, I'm here. Drop a mail or you can drop a message anytime 24 by 7, right? Wish you all the best, love you all, and I hope you'll sleep early, including myself, so that we can attend tomorrow's live session at 5 a.m. We'll start sharp at 5. We'll try to start sharp at 5 to 5:10, between 5 to 5:10 a.m. So with lot many questions from complete denture, RPD, FPD, as well as occlusion, we'll try to cover as many questions as possible. I framed 15, so we'll just go ahead with discussing those 15 questions. Right. At our time, it was in March. The exam was in March. It was in March, first week. Yeah, right. So once again, wish you all the best. Keep the momentum going. Just stick on to your grit. Just you can do it. So it all comes with confidence. It's not just extrinsic motivation. So keep on working towards what you're doing. It doesn't matter how you score or how much you score, as long as you're learning, right? So keep on working hard, smart, give you 100% and give your best. Best comes to you, and always be optimistic. Always be dangerously optimistic. Devo, do, right? So see you tomorrow at 5 a.m. And I hope we'll have more attendance tomorrow morning as well, right? So bye. Good night. Love you all.